Welcome back to the Deep Dive. Today, we're really diving into liver failure. It's such a complex condition, isn't it? It touches pretty much every system in the body. Understanding it, well, it really means grasping how interconnected everything is.
Absolutely.
So whether you're prepping for, say, a med school oral exam, or you're just really curious about how the body works, or maybe how it doesn't work sometimes.
Yeah,
This deep dive is definitely for you.
that's right.
Our mission today, it's pretty straightforward. We want to break down the essentials of liver failure.
Okay.
We'll look at the different forms, what causes them, and crucially, how failure in the liver triggers this whole cascade of effects throughout the body.
Yeah, the ripple effect.
Exactly. We want you to walk away with a really clear, memorable, and clinically useful understanding.
I think that's key because the liver, it really is the body's metabolic powerhouse, isn't it? It's doing hundreds of things, detox, synthesis, filtering.
Yeah, the central processing unit, you could say.
Yeah, precisely. So when that starts to fail, it's not just a local problem. It kicks off this profound systemic crisis. It really hits home just how vital the liver is.
Okay, so let's start with classification. You mentioned it's complex.
Yeah.
Liver failure isn't just one thing, right? There are different types.
Exactly. Getting the types straight is fundamental. So first off, we have acute liver failure, or ALF.
ALF. Okay.
This is defined by rapid and massive hepatocyte necrosis. So basically widespread liver cell death. And critically, it happens in a liver that was previously healthy.
So no underlying chronic disease there.
Correct. That previously healthy part is a really key diagnostic point. It's a sudden, devastating event.
Right, often without much warning, I imagine.
That's often the case. The causes are typically acute insults. The most common one we see is acetaminophen overdose, especially dangerous when combined with alcohol that really amplifies the toxicity.
Okay, good to know.
Other causes. Well, there's the infamous Amanita phalloides mushroom, the death cap.
Nasty stuff.
Definitely. And certain viruses, mainly hepatitis A and B, can also trigger ALF. Pathologically, the liver itself changes dramatically. It becomes soft, sort of flaccid, pale yellow, or even reddish. And it shrinks. The weight can drop significantly, down to maybe 800 to 1,000 grams.
Wow, that's a huge drop. Speaks to the massive cell death you mentioned. So what's the clinical picture like? Fast.
Extremely fast and dramatic. Patients might seem okay initially, but then they rapidly progress to multi-organ failure. We're talking days, maybe weeks.
Oh, wow.
And honestly, without an urgent liver transplant, the prognosis is, well, it's very poor. Death can happen very quickly. It's a true medical emergency.
That really paints a stark picture. Okay, so that's acute. But you mentioned a chronic form, too. That sounds like a very different beast. Slower, maybe?
Exactly. A total contrast, really. That's chronic liver failure. This develops over a much longer time frame, months or years, and it happens on the background of existing chronic liver disease.
Okay, so there's pre-existing damage here.
Yes. But the key difference from ALF is that you don't see that massive sudden necrosis. Instead, it's a gradual, progressive loss of the liver's metabolic function. The cells just slowly stop doing their jobs properly.
So it's more about function fading away rather than a sudden structural collapse.
Precisely. A slow functional decline. What you typically see is maybe an enlarged liver, sometimes yellowish. And pathologically, a key distinction there isn't usually significant inflammation like an ALF.
Okay.
Diagnosis often relies on tracking abnormal liver function tests over time. They just stay persistently off. As for causes, think things like poorly controlled diabetes mellitus that can lead to glycogenic hepatopathy.
Glycogenic hepatopathy, what's that exactly?
It's where excess glycogen gets deposited in the liver cells, impairing their function. Chronic infections like hepatitis C are another common cause. It's usually the result of sustained long-term insults to the liver.
Got it. So ALF is sudden, chronic is gradual. And then you mentioned a third type, sort of a mix.
You got it. That's acute on chronic liver failure, or ACLF. This is when a patient who already has chronic liver disease, usually cirrhosis, that's severe scarring.
Right, the irreversible scarring.
Exactly. So they have that underlying damage, and then some acute event happens, maybe an infection or perhaps heavy drinking bout.
Like a trigger event.
Yes, and that trigger causes a sudden severe deterioration. Pathologically, you see both things happening. New hepatocyte necrosis, like an ALF, but it's happening on top of the existing fibrosis and cirrhosis.
That sounds incredibly dangerous, combining The worst of both worlds, almost.
It's a very precarious situation. You have the rapid decline of acute failure hitting a liver that already has very little reserve capacity due to the chronic disease.
So understanding these distinctions, ALS, chronic, ACLF, it's absolutely crucial then for diagnosis, prognosis, how urgently you need to act.
Absolutely critical. The management and the likely outcome can vary enormously between them. Getting that classification right and fast is paramount.
Okay, this is where things get, well, really fascinating and also quite frightening. Once the liver starts failing, it's not just the liver that suffers. It kicks off this whole cascade throughout the body. What are the major systemic consequences we see?
Right, this is the domino effect. A huge one to start with is portal hypertension.
Portal hypertension.
Okay.
High pressure of the portal vein.
Exactly. It's a sustained increase in pressure in the portal venous system, that network of veins bringing blood to the liver from the gut and spleen.
And what causes that pressure to spike? Is the liver just blocking the flow?
That's the core issue. The mechanism is usually sinusoidal dysfunction. Basically, there's increased resistance to blood flowing through the liver's tiny blood vessels, the sinusoids.
Right.
This blockage, this resistance, it can happen at different points. Sometimes it's presinusoidal before the sinusoids. You might see that with fatty liver. Sometimes it's sinusoidal right within them, which is typical for hepatitis or cirrhosis. And sometimes it's post-sinusoidal after the sinusoids, maybe due to fibrosis or vascular changes. But wherever the bottleneck is, blood starts backing up.
Like a traffic jam.
Yeah.
So if blood can't get through the liver easily, it backs up. What does that do to the body? What are the consequences?
Oh, they're severe and widespread. First, that backed up blood causes varices. These are swollen, very fragile veins.
Like varicose veins, but internal.
Kind of, yes. And they're particularly dangerous in the esophagus and stomach. They can rupture easily and cause absolutely massive, life-threatening gastrointestinal bleeding.
Wow. Okay, that's serious. What else?
Well, the backup and changes in flow lead to widespread splanchnic vasodilation.
Splanchnic vasodilation.
Yeah.
So the blood vessels in the gut widen.
Exactly. They relax and widen significantly. This contributes to nutrient malabsorption. And also mucosal ischemia, reduced blood flow to the lining of the gut.
Which would make it vulnerable.
Precisely. Higher risk of ulcers and infections like peritonitis, which is inflammation of the abdominal lining. But there's another critical consequence of that vasodilation.
It drastically reduces the effective circulating blood volume. Even if the person has a lot of fluid overall, the main circulation feels depleted. The kidneys sense this as dehydration or low blood pressure.
So the kidneys get tricked.
They do. This causes renal hypoperfusion, reduced blood flow to the kidneys. And that triggers the body's emergency system, the renin-angiotensin-aldosterone system, or RAAS.
RAAS, right, the system that normally raises blood pressure.
Correct. But here, its activation leads to excessive sodium and water retention. The body desperately holds on to fluid. This causes widespread edema, swelling, and particularly that massive fluid buildup in the abdomen we call ascites.
And didn't you say earlier that poor protein synthesis makes ascites worse too?
Exactly. The low albumin from liver failure adds to the fluid leak. And one more thing from portal hypertension. The body tries to find detours for the blocked blood. It creates portosystemic shunts.
Shunts, like bypass routes.
Yes, sometimes you can even see them visibly, like swollen veins around the navel. That's called caput medusae.
These shunts do relieve some pressure, but there's a huge downside. Blood-carrying toxins from the gut now bypasses the liver's detoxification process entirely.
Oh, so the toxins go straight into the main circulation.
Correctly. And that leads straight into our next major complication, hepatic encephalopathy.
Makes perfect sense. If the liver isn't clearing those toxins, especially from the gut, and they get shunted around it, what happens when they hit the brain?
That's hepatic encephalopathy. It's a neuropsychiatric syndrome, basically brain dysfunction, caused by toxins the failing liver can't clear. The main culprit we talk about is ammonia.
Ammonia, right.
We tend to classify it into two main types. There's acute hepatic encephalopathy, which you might see in fulminant liver failure. It can progress really rapidly to coma, seizures, even dangerous brain swelling, cerebral edema.
Very severe.
And then there's chronic, sometimes called portosystemic encephalopathy. This is usually more gradual, more insidious. You see things like confusion, changes in personality or behavior, disrupted sleep patterns, problems with coordination.
Isn't there a specific tremor associated with it?
Yes, absolutely. A characteristic flapping tremor called asterixis. They call it the liver flap. Patients might also develop apraxia, difficulty with skilled movements.
So how does ammonia actually mess with the brain? What's this mechanism there?
Well, ammonia is small and it easily crosses the blood-brain barrier. Once inside the brain, it gets taken up by specific cells called astrocytes. They try to detoxify it by converting it to glutamine.
Okay.
But this process uses up glutamate, which is a key excitatory neurotransmitter. At the same time, it seems to lead to an increase in GABA, which is the brain's main inhibitory neurotransmitter.
Ah, so it decreases the go signals and increases the stop signals.
That's a great way to put it. It essentially dampens overall brain activity, leading to all those neurological symptoms. Management often involves things like a low-protein diet to reduce ammonia production in the gut.
Right.
And medications like lactulose. Lactulose works in the colon. It lowers the pH, which traps ammonia as ammonium ions, NHO, which aren't absorbed as easily, so more gets excreted.
Fascinating mechanism. Okay, so beyond filtering toxins, the liver is this incredible factory, right? Making protein, storing energy. When that factory shuts down, what key things stop being made or processed correctly?
Oh, the metabolic and synthetic failures are massive. One early thing you might see is hypoglycemia, low blood sugar, especially after meals because the liver can't store glycogen properly or make new glucose effectively.
Okay.
Energy crisis.
And a huge one, decreased protein synthesis. This leads to hypoalbuminemia, low albumin levels. Albumin helps keep fluid in the blood vessels, so when it's low, fluid leaks out, causing that widespread systemic edema and making the ascites much worse.
Right.
Even more critical, perhaps, is the lack of clotting factors. The liver makes most of them. Without them, you get coagulopathy.
Impaired blood clotting.
Exactly, which means a very high risk of bleeding. Think about that, combined with the varices we talked about earlier.
Yeah, that's a recipe for disaster. Low clotting factors plus fragile veins ready to bleed. It's an extremely dangerous combination. And the metabolic chaos continues. You often see lipid metabolism disorder, which can result in hepatic steatosis or fatty liver accumulation.
Okay.
There's also decreased bile production. Bile is crucial for digesting and absorbing fats. So without enough bile, you get fat malabsorption, leading to steatorrhea, fatty, greasy stools.
Makes sense.
We can even see disturbances in acid-base balance, like metabolic alkalosis, partly because that excess ammonia acts as a weak base in the body.
Just affects everything. And what about hormones? I know the liver metabolizes hormones too.
Yes, another critical function. When the liver fails, it can't inactivate hormones properly, so they build up.
Oh.
For instance, decreased inactivation of testosterone allows more of it to be converted to estrogen in peripheral tissues.
Yeah.
In men, this can cause gynecomastia, breast enlargement.
Okay, I'd heard of that.
Similarly, decreased inactivation of estrogens leads to overall hyperestrogenism. In women, that might mean menstrual irregularities. In both sexes, you might see things like spider angiomas on the skin or palmar erythema, red palms.
Right.
And finally, the liver also inactivates aldosterone. So decreased inactivation leads to secondary hyperaldosteronism, which, remember, makes the body retain even more sodium and water, worsening the edema and ascites. It's a whole endocrine mess on top of everything else.
It really sounds like the kidneys often get dragged down with the liver. You mentioned hepatorenal syndrome. Can you elaborate on that link? How does liver failure lead to kidney failure?
Absolutely. Hepatorenal syndrome, or HRS, is a really feared complication. It's basically kidney failure that happens because the liver is failing, even though the kidneys themselves might be structurally okay.
So it's functional kidney failure, not damage to the kidney itself.
Exactly. It's functional. And the mechanism ties back directly to portal hypertension and that profound splanchnic vasodilation we discussed. Remember how that tricks the body into thinking blood volume is low?
Right, leading to renal hypoperfusion.
Precisely. The kidneys get starved of adequate blood flow. In response, they clamp down hard. The RAS system goes into overdrive, and sympathetic nerve activity ramps up, causing intense vasoconstriction within the kidneys.
So even though the body is overloaded with fluid overall, the kidneys are constricting their own blood supply.
That's the terrible irony. It leads to a further sharp drop in blood flow to the filtering units, the glomeruli. So you get this marked oliguria, very low urine output, a rapidly falling glomerular filtration rate, GFR, and rising waste products like creatinine and urea in the blood.
Okay.
You also often see dilutional hyponatremia sodium levels look low because there's so much excess water retained. And sometimes hypokalemia, low potassium, which is dangerous because it can cause arrhythmias and muscle weakness.
It's just one hit after another.
Okay.
Okay, one more piece. The spleen. How does the spleen get involved in all this?
The spleen gets pulled in directly because of the portal hypertension. Remember, the spleen drains into the portal vein, so when pressure backs up in the portal system...
Backs up into the spleen tap.
Exactly. Blood gets congested in the spleen, causing it to enlarge. That's congestive splenic enlargement, or splenomegaly. Now, an enlarged, congested spleen often becomes overactive in its job of filtering blood cells. We call this hypersplenism. It starts removing too many cells from circulation.
Which cells specifically?
It can affect red cells and white cells, but it particularly traps and destroys platelets. This leads to thrombocytopenia, a low platelet count.
And platelets are crucial for clotting.
Critically important. So hypersplenism adds another reason for the increased bleeding risk in these patients, on top of the lack of clotting factors. See how it all interconnects.
It's truly a web. Okay, let's try and synthesize this. We've covered a huge amount, the types of failure, the systemic consequences. For someone trying to lock this in, maybe for that oral exam, what are the absolute key takeaways, the must-know points from this deep dive?
Okay, let's boil it down. For recall, acute liver failure, ALF. Think rapid onset, often toxins like acetaminophen or viruses, massive necrosis, needs urgent transplant evaluation.
Sudden catastrophe.
Chronic liver failure. Slow, gradual functional loss on top of existing disease. Minimal necrosis usually, more about the metabolic signs building up over time, often from things like chronic hepatitis or diabetes complications.
Most slow burn.
Acute on chronic, ACLF. A sudden worsening in someone already cirrhotic. Very high mortality, triggered by an acute event.
Got it. The explosion in a compromised system.
Then the big consequences. Remember, portal hypertension is the central driver. Think varices and GI bleeding, ascites, and the shunting that leads to encephalopathy.
Okay, portal hypertension is key.
Hepatic encephalopathy, primarily driven by ammonia bypassing the liver. It disrupts brain function by messing with neurotransmitters specifically, increasing inhibitory GABA, decreasing excitatory glutamate. Look for asterixis.
Ammonia, GABA, glutamate check.
Synthetic failure, this is huge, leads to hypoalbuminemia, causing edema and ascites, and crucially, lack of clotting factors, causing coagulopathy and bleeding risk. Also, hypoglycemia.
Edema, bleeding, low sugar.
Okay, hepatorenal syndrome. Functional kidney failure due to systemic vasodilation and intense renal vasoconstriction driven by RAAS. Remember, the kidneys themselves aren't initially damaged.
Functional kidney failure from RAAS.
Right. And don't forget hormonal imbalance, signs like gynecomastia in men, menstrual issues in women, spider angiomas. These point to the liver failing to clear hormones, and the splenomegaly leading to thrombocytopenia.
Adds to the bleeding risk.
Exactly. Understanding how these pieces all fit together, how one problem triggers the next, that's really the core of understanding liver failure clinically.
Thank you. That synthesis is incredibly helpful. You've guided us through something immensely complex with real clarity. It really hammers home how dependent all our systems are on each other, especially the liver.
It's my pleasure. It really is a testament to the liver's central role.
It leaves you with a lot to think about.
Absolutely. And maybe a final thought for you to mull over. Consider how this organ, the liver, works silently in the background most of the time, acting as the central processing unit, managing hundreds of tasks. When it fails, the effects aren't just local, they ripple outwards and fundamentally challenge the body's entire functional balance. It really makes you appreciate the delicate equilibrium our bodies constantly fight to maintain, doesn't it?